Question number 129, inflammatory bowel disease. In this question, I'm going to do a side-by-side rundown of the two most prevalent diseases that are relevant in this question stem. And we're going to go through their features, their similarities, and their differences. And then, as the other part of the question has, we also have to discuss some other non-infectious intestinal inflammations apart from inflammatory bowel disease. So, inflammatory bowel disease, or what is it? Inflammatory bowel diseases, by definition, are just a group of diseases. So they are a group of diseases that are characterized by chronic. So that's an important word you need to remember. It is a chronic inflammatory process, recurring, meaning that you have phases of relapse and remission respectively. So, a group of diseases that are characterized by chronic recurring inflammation of the bowel wall. And there are the two most common diseases that fall under inflammatory bowel disease is Crohn's disease and ulcerative colitis. We're going to do a simultaneous rundown on some of the differences in some of the important features prevalent to both of these diseases. What you need to know before we really get into it as far as etiology goes is that both of these are idiopathic in nature, but they have been attributed to an autoimmune process. So it does correlate with defective immunity, meaning that a patient who does present with this may have some genetic predisposition to the disease, and there may be environmental triggers that are also relevant to causing both of these diseases. And in some cases it also has to do with the disbalance of the microflora of the GI tract. So just to list down the causes, patients will have a genetic predisposition and an environmental trigger that interacts with said predisposition, and it may also involve disruptions in the regular microflora. Cool. So as far as autoimmune involvement goes, the first place to start off is that we can talk about some of the immune system cells and the genetic abnormalities that are associated with both ulcerative colitis and Crohn's disease. So for ulcerative colitis, one of the more predominantly involved immune cell lineage that is seen is the involvement of Th2 cells, and these cells are responsible for secreting interleukin 5 and interleukin 13. Of course, you don't really need to know the specific details of what the cell does, but just for your knowledge and an overview of the entire picture, Th2 cells mediate the activation and maintenance of the antibody mediated response. So I'll just put that down, maintenance of antibody response. I'm not really going to go into too much detail of what all of these cells do. It's just for the sake of you guys knowing that these are the immune cells that are involved in both of these diseases, because we've discussed and described that both the processes have an autoimmune relation. The second type of cells that have been seen are antibody producing cells known as P ANCAs. You'll remember this from the vasculitis lecture, that P ANCAs are perinuclear antineutrophilic cytoplasmic antibodies. That's really just about it. I don't really want to go into too much detail of it. And then the last type of cell that is implicated in ulcerative colitis is cytotoxic T cells. So the cytotoxic T cell activation and its mediated cytotoxic killing is also seen in ulcerative colitis. Moving on to Crohn's disease, cells implicated in this are Th17 cells, which are responsible for the secretion of interleukin 17. And all you really need to know in this case is that Th17 cells play a crucial role in the induction of tissue inflammation. So inflammation induction. And then we've got another cell type that is involved, which you'll be more familiar with, which is the Th1 cell lineage. This is responsible for secreting pro-inflammatory cytokines, which you will remember: TNF alpha, interleukin 1, interleukin 6. And Crohn's disease is also said to be linked with a specific genetic mutation, which is the NOD2 mutation. And that this gene is normally involved in controlling immune responses and inflammatory reactions, and it is implicated in Crohn's disease. So, coming to the distribution of ulcerative colitis and Crohn's disease. First thing that we need to know for ulcer, just remember as we keep moving, the left hand side is ulcerative colitis and the right hand side is Crohn's disease. So, back to distribution. As far as ulcerative colitis goes, its distribution is localized to the large intestine, or as you can tell from the name itself, colitis, to the colon. So large intestines and the colon rather. And the inflammatory process that is associated with ulcerative colitis can involve the entire colon or the entire organ, or just a portion of it. And another important feature as far as distribution goes is that the most common site that is affected by ulcerative colitis is the sigmoid colon. Compared to ulcerative colitis, Crohn's disease can occur in any part of the GIT. So literally anywhere from the mouth to the anus. And thus a differentiating factor from ulcerative colitis is that both the small and the large intestines are involved in Crohn's disease. As compared to just the large intestine or the colon being involved in ulcerative colitis. As far as the prevalence of the disease goes, ulcerative colitis has a higher prevalence and Crohn's disease has a lower prevalence, but the severities unfortunately are the other way around. The severity of ulcerative colitis is relatively less as compared to Crohn's disease. Some clinical presentations that may be seen in the patient: normally you will have abdominal pain according to lesion location, diarrhea, which we have to differentiate being bloody or not, and fever. These are normally the general clinical findings that you will see in a patient who has inflammatory bowel disease. But to differentiate them, ulcerative colitis is normally more indicative, rather bloody diarrhea is relatively more indicative of ulcerative colitis, whereas in the case of Crohn's disease, diarrhea is usually not bloody. And you can imagine why this is true, because if you have lesions that are more commonly prevalent in the large intestine or in the colon where the bulk of your feces are formed, defects within the wall of the colon are more likely to cause you having passing out stools that have blood in them, as compared to if the lesions were more localized relatively to the small intestine where stool formation does not take place, and thus less chances of having bloody diarrhea. That's why it's usually not bloody in the case of Crohn's disease, but it can happen. Now, as far as abdominal pain goes, you'll see that Crohn's disease the patient normally always presents with abdominal pain, whereas in the case of ulcerative colitis, this pain is usually often before passing stools. And this normally feels like cramps, whereas in the case of Crohn's disease, this is usually a more severe and sharper pain. Then the next feature that we need to talk about, which differentiates ulcerative colitis from Crohn's disease, is the presence or the absence of skip lesions. And the first thing you need to know is, by definition, what a skip lesion actually is. And so skip lesion in inflammatory bowel disease basically refers to inflammation and damage of the GI tract. So inflammation plus damage of the GI tract that are separated by segments of less affected or absolutely normal tissue. By segments of less damaged or completely normal tissue. And so in ulcerative colitis, these skip lesions are absent, and the type of lesions that we describe in the case of ulcerative colitis are more diffuse in nature, diffuse lesions. Whereas in the case of Crohn's disease, we can say that skip lesions are present. So you can see that we have regions of completely normal tissue that is not affected by any inflammatory process, which occurs with this normal tissue is normally present in between affected areas. And so you may hear that the lesions of Crohn's disease are described as segmental or patchy in nature. Right, now coming to the microscopy, which is probably one of the more important details you need to be able to describe with respect to both of these diseases, is the type of ulcers. Once again, you should be able to differentiate between what an ulcer is and what an erosion is. This is not an erosion. This is always going to be an ulcer for the most parts. And so by definition, an ulcer involves a defect that runs through the mucosa past the muscularis mucosa. And so if I draw a little diagram out here just to explain the difference. Let's say we have our bowel wall. We look at the histological structure. We've got the mucosa, we've got the muscularis mucosa, and then we've got the submucosa. If you have a defect that runs only onto the surface of the mucosa, the surface epithelium of the mucosa, and does not invade past the muscularis mucosa, this is an erosion. Whereas if the defect runs through the muscularis mucosa and further runs into the submucosa, this is an ulcer. So please be able to differentiate between this, because when more often than not, if you bring up the terms erosions or ulcers in the exam, you will be asked to differentiate between the two of them. So anyways, coming back to the morphology of the ulcers that are seen in ulcerative colitis and Crohn's disease. As you can tell from the diagram itself, ulcerative colitis normally presents with more superficial ulcers, and again, because these are ulcers, they will have mucosal involvement that runs through the muscularis mucosa and submucosal involvement as well. But these are the only two layers of the ulcers these are the only two locations rather of the bowel wall where the ulcer is present. So you usually only have mucosal and submucosal ulcerations that are seen with respect to ulcerative colitis, sorry. And another important as far as describing morphologically what these ulcerations look like, you can already see it in the picture. These are what we describe to be pinpoint defects. Comparing this now to Crohn's disease, we can see that these are knife-like fissures. So imagine running a knife right through there. Knife-like fissures. These morphologically, at the microscopic level, are usually linear and they are deep fissuring. And the term that is used to describe these defects is transmural ulcers. So you can see that this runs through all of the layers that make up the bowel wall. So that's your mucosa, your submucosa, your muscularis propria, and then yours, not drawn here, but it can also involve your serosa. Whereas in the case of the superficial ulcers we saw in ulcerative colitis, these only involve the mucosa and the submucosa at max. That's about it. The next defining feature to differentiate between these two diseases is the presence or the absence of a fistula. And so by definition, that means first you need to know what a fistula is. And a fistula, I'm going to zoom in here to write it down. A fistula is basically an abnormal connection that forms between two organs or an organ and the skin. So abnormal connection between two organs or between an organ and the skin. And these are normally associated with inflammatory conditions, other inflammatory conditions where you can see fistulas apart from the ones we're just going to discuss right now are diverticulitis or secondary to some infections. Anyways, so coming back to the presence or the absence of fistulas, it should be quite easy to understand really. If you're having an abnormal connection running from one organ to another, you would imagine that it needs to have a defect, a deep defect that runs through the entire wall of the bowel in this case. And so quite easy to understand that a fistula will normally be absent in ulcerative colitis but present or a likely complication in Crohn's disease. So it's relatively common in Crohn's disease. And then you may be asked what type of fistulas can be seen with this disease process. Don't worry, quite simple to think about it quite logically. You can have enterocutaneous fistulas, which basically means you have a fistula forming between the intestine and the skin. You can have enteroenteric fistulas, which basically means that the fistula occurs between two segments of the intestine, creating a connection that allows for the contents to flow from one part of the intestine to the other. Now with Crohn's disease, obviously this can occur between the large intestine and the small intestine, but it can also develop between different loops of the small intestines as well. And then other types that you can see are enterovesical, which means that you have a fistula that is formed between the intestine and the bladder, leading to the passage of stool or gas into the urinary system. Or in females, you can also have enterovaginal fistulas, and in both female and males you can have only in females again, sorry about that, you can also have rectovaginal fistulas. So again, just think about the anatomy and all of the organs that lie close to the intestines and you should be able to formulate where the fistulas can form. So the next feature that we've got to talk about is the bowel wall appearance. And usually in ulcerative colitis, the bowel wall appears thin, whereas in Crohn's disease it appears thick. And the reason it appears thickened in Crohn's disease is because again you have a transmural involvement or transmural inflammation taking place. So all of the layers of the bowel wall are involved, giving it a thick appearance. However, an important thing to understand, and this applies to both ulcerative colitis and Crohn's disease, is what happens in the cases of advanced diseases. So if this disease goes on for way too long without any treatments being medical treatments or surgical treatments being offered in advanced diseases, because you will have repeated cycles of inflammation and healing which occurs through fibrosis, you can see that the wall will become completely featureless, and that is when we describe this the wall of the intestine to resemble a lead pipe. You know how pipes are in general, they have absolutely no features, just plain flat running pipes. That's how it is. That's literally how you describe the appearance of the bowel when the inflammatory process is going on for a long period of time. The next defining feature that we need to talk about is whether or not we have a cobblestone appearance. And so what this basically means is that if you can imagine the wall of the intestines and you look into it morphologically, it would look something like this, a cobblestone appearance of sorts. And why this is occurring is because you have deep mucosal ulcerations mixed with nodular submucosal thickening. And what this basically means is that you have deep ulcers that are arranged longitudinally along the length of the bowel, that is involved, and this results in this cobblestone appearance. And so a key giveaway here that I've already mentioned is deep mucosal ulcerations, and only one of these two diseases has deep ulcerations relatively deeper ulcerations as compared to the other. And so the cobblestone appearance is normally absent in ulcerative colitis, whereas it is usually present in Crohn's disease. The next defining feature that helps us differentiate between these two diseases is the presence or the absence of pseudopolyps. And as the term implies, a pseudopolyp means that these are not polyps in true actuality. So not true polyps. And why these are not true polyps is simply because you look at a regular mucosa. So this is a regular mucosa, and when you have defects that are being created in these mucosas, you can see that you will have an appearance that looks something like this diagrammatically. This represents basically this is a representation of residual edematous islands of mucosa. And so it's really common sense if you think about it. You have a linear mucosa and you have pinpoint ulcerations taking place at multiple points. It makes the relatively healthier and remaining mucosa appear as if it is a polyp, as if it is a protrusion of the mucosa. But as a polyp is by definition, it is an outpouching of the mucosa. In this case, there is absolutely no outpouching taking place. It's just that you have defects surrounding these edematous islands of mucosa, making it look like as if you have polyps. And so this is obviously only going to be seen in ulcerative colitis. It's going to be absent in the case of Crohn's disease. The next feature we need to talk about is fat wrapping. And what this basically means is that you have abdominal fat migrating to the wall of the inflamed intestine. And this is more commonly seen when you have transmural inflammation. Now only one of these two disease processes has transmural inflammation, and so fat wrapping is usually absent in the case of ulcerative colitis but present in the case of Crohn's disease. Right, then coming on to the types of inflammatory cells that you can see with both of these diseases. The type of inflammatory cell that is normally seen in ulcerative colitis is acute. That means your neutrophilic infiltrate, and chronic, meaning your lymphocytic infiltrate. So both acute and chronic inflammatory cells can be seen in the case of ulcerative colitis. Compare this to Crohn's disease, which is relatively more long-standing. You will see chronic inflammatory cells present in abundance. So chronic, meaning your lymphocytes are more likely to be present, and because of the abundance in which these chronic inflammatory cells are present, you may see the formation of lymphoid aggregates, so follicles, and even the presence, which we're just going to discuss moving down anyways, presence of granulomas as well, and these are usually non-caseating. So crypt abscesses. Abscesses, as you know, is a collection of pus that is localized, and so if you imagine the wall of the intestine, we know that we've got crypts, and because you normally have a acute or neutrophilic infiltrate is normally more commonly seen in ulcerative colitis, crypt abscesses are more commonly seen in ulcerative colitis as compared to Crohn's disease. These are relatively uncommon. Granulomas. Now obviously like we already mentioned, there is a larger abundance of chronic inflammatory cells in Crohn's disease, and so granulomas, non-caseating ones, are more common and present in Crohn's disease. They're non-caseating, whereas they are usually absent in ulcerative colitis. Now coming to the complications that can be associated with both ulcerative colitis and Crohn's disease. So the first one with ulcerative colitis is something we call fulminant colitis. And what fulminant colitis basically means is that you have a severe and rapidly progressing form of inflammatory bowel disease, especially in this case being ulcerative colitis, and that you have a very, I wouldn't say distinct, but a rather more severe presentation of symptoms that are associated. So you will have some of the symptoms we discussed already, but just in a more dangerous or life-threatening circumstance. So severe diarrhea, normally bloody, increased abdominal pain, so severe abdominal pain, urgency in your bowels, fever, increased white blood cell count, weight loss, dehydration, and nausea plus vomiting. The next complication is a toxic megacolon, and this is relatively rare but potentially life-threatening, and it is basically characterized by severe inflammation and dilation of the large intestine. So if you can imagine, this is what our colon would normally look like. You can imagine the inflammatory process makes it much larger, much more dilated, and this leads to a significant increase in its diameter. And the reason this is considered to be severely life-threatening or a potential life-threatening complication is because you have an increased risk of perforation, you have an increased risk of septic shock, and thus a quick and sad death as well. Another important complication, which I don't have space to write down, I'll try fitting it in here, is that ulcerative colitis is also and it's normally also associated with primary sclerosing cholangitis, and this is because the autoimmune cells that are involved in ulcerative colitis, which we discussed at the start of the video, are normally also involved in primary sclerosing cholangitis. And one last risk worth discussing is an increased risk of colorectal carcinoma. Right, coming to the complications associated with Crohn's disease, quite simple. We already discussed it. The first one rather is the formation of fistulas. Another important complication is the formation of strictures, which can further precipitate bowel obstructions, and it increases the risk of colorectal carcinoma, and also the risk of, which is, these cancers are normally relatively rare, but also an increased risk of small bowel cancer. One other thing that is worth knowing between the two of them, I will go back and mark it down, is that smoking is actually a protective factor in the case of ulcerative colitis. Thank you, House MD. And on the other hand, it is unfortunately a risk factor in the case of Crohn's disease. So something worth knowing, nice thing to know. And lastly, the question does require you to discuss some other non-infectious inflammatory bowel diseases. Rather, it requires you to discuss other non-infectious intestinal inflammation, sorry. And there are normally just three worthwhile noting. These are NSAID-associated enteropathy. So NSAID-associated enteropathy, which as the name suggests quite literally, is seen as a form of intestinal inflammation due to chronic NSAID use. So chronic NSAIDs, non-steroidal anti-inflammatory drugs use can result in inflammation of the bowel wall, and this can normally present morphologically with both erosions and ulcers. Second type is radiation associated enteritis, so inflammation that occurs secondary to radiation, and this is quite simple. You've got epithelial cells lining your bowel wall. Radiation is bad for them, it kills them off. And so normally in the cases of acute radiation, you can see necrosis of these necrosis of the epithelial cells in acute and short-term exposure. You can see diarrhea in patients, whereas in the case of chronic radiation exposure, you can see strictures being formed, which are basically fibrous bands that attach different parts of the bowel lumen, bowel wall in this case, and this then leads to constipation. So completely polar opposite clinical presentation. And these strictures can undergo further organization, which can result in a decreased blood supply to the wall of the intestine, and these normally also heal by fibrosis. So that's worthwhile noting. And the last one is necrotizing enterocolitis. No, I'm not going to discuss too much of this because it does have a bit of a infectious etiology, but what you need to know is that you have an inflammatory process at the level of the bowel wall, which leads to necrosis and hemorrhage. Excuse my spelling mistake. Necrosis and hemorrhage, and this can further precipitate a gangrene due to a bacterial superinfection. This is normally seen in immature infants because their intestines have not fully developed. And that should basically wrap up this entire question. Focus more on obviously Crohn's disease and ulcerative colitis, talk about their differences, talk about its similarities wherever possible. There are barely any similarities for that sense, apart from the fact that they both form ulcers. And yeah, you should be good with this question, and that's about it.